second day of the commissioning conference. My name's Michael Dixon. I'm a GP in Devon, sometimes. I'm also Chair of NHS Alliance and standing President of NHS Clinical Commissioners, representing clinical commissioning groups throughout the country. Now, so much for me. Very many thanks for allowing me to come this morning. I understand you had a very interesting day yesterday. I'm sorry to miss Norman Lamb, but please do put in your applications to become the integrated pioneers. Remember, the closing date is the end of the month, and it's absolutely crucial that we get some really good integrated proposals coming from primary care, integrating services with secondary care and also with social services. I understand you also heard from Andy Burnham, Shadow Secretary of State yesterday, and let's hope that he thinks a little bit more carefully about his plans to devolve budgets from CCGs to health and wellbeing boards. Maybe it's a little bit premature to be talking about this, given that as CCGs we're just 2.5 months old. Now, I just want to take the temperature in this room this morning before we start. So one general question and one specific question. So the general question is, in your personal life, where do you belong at this moment in time? Do you view life positively? Is it vaguely okay? Or is it just a little bit crunchy, a little bit difficult, hoping to get through the challenges, but not so good? Now, you've got to say either good or bad. So who thinks that their life at the moment is in a good place? And who thinks their life at present is in a bad place, or not so good place? Well, that's a good start. Now for the specific question with which we'll be comparing your answers. Who thinks positively about the way the NHS is going? Who thinks that tomorrow things are going to get better? And who thinks we're all going to die, it's going to get worse, we've had it, and we might as well just stay out the next few years and hope that we're at least alive? So who is positive about the future? And who is a little bit negative about the future? Gosh, I mean, that's about the same as the previous vote, and I wonder how much feelings on the NHS reflect our personal lives, and I suppose they do. Thank you, that was very useful. So we've got a positive audience, and I'm very sorry that yesterday I couldn't have been with you, because yesterday, sadly, I had to be in surgery on pain of death from my partners and patients. And like most GPs, I started fairly early and was still there 12 hours later. And like most GPs, I began the day with energy and trepidation as duty doctor, and ended the day physically and emotionally exhausted, haunted by those terrible feelings of inadequacy as you try to get through the day, armed only with a few tablets, a few skills and some experience against that endless ocean of suffering and despair. Yet, what a privilege it is for us clinicians to be in the inner sanctum of people's lives every day, to witness the world as it really is, to balance those square pegs of biomedical guidelines with the round pegs of people's lives, to recognize the power of narrative over statistics. And that, ladies and gentlemen, is exactly why it is crucial, entirely appropriate, even obvious, that frontline clinicians should have become the new clinical commissioners. Because how else will the NHS balance science with humanity and economics with compassion? And it's singularly failed to do that to date. And I believe that clinical commissioning groups and their leaders and their managers will be able to make those balances. But the most crucial question of all is, will they be able to fully connect with the everyday experiences of those frontline clinicians who are making decisions with patients at the front line? Will those CCGs and their leaders be able to connect with those frontline practices and clinicians? Because only through that connection can we begin to tackle the silent epidemic of long-term disease, and only through that connection can we gain that level of financial sustainability that the NHS so crucially requires. Now, before you tweet and Twitter that Dixon is just a great Mary Poppins on speed, I'd like just to be a little bit clear, because these are challenging days and there are many, many challenges ahead. For general practice and primary care, those challenges are immense. Doctors want to provide personal care, but the tick box culture is beginning to get in their way. They want to provide more in general practice, but they can't do that without resources. When I went into general practice 30 years ago, there were 3 times as many GPs as there were specialists. Last year, there were more specialists than GPs. And you know the statistics. In the last 5 years, the share of the NHS budget for general practice has gone down from 10% to 8%. Last year alone, and these are Nuffield Trust figures, the amount of money going into secondary care went up by 1.4%. The amount of money going into general practice went down by 1.4%. Now, general practice can do the impossible, but it can't do the impossible on thin air, or should I say hot air. We do need the resources if we're going to achieve these things. And clinical commissioners have an equally enormous challenge. For a start, how can they balance the budgets when everyone seems to be having dawn raids on their money? That's the specialist commissioners, PropCo, the unpaid bills due to continuing care, not to mention the continuous collection of contingency funds. And how can they get the headroom to redesign, innovate, and take risks, which is so crucial if we're going to create a cost-effective NHS, if everyone else is perpetually telling them what to do? They're going to need enormous support, both from their frontline clinicians and managers, but also from the support units. And it's great to see so many of the commissioning support units here today. Now, NHS England has supported ministerial reassurances that from now onwards it's going to be assumed liberty, not that awful, ghastly, earned autonomy. And commissioners should commission, therefore, only as they see fit and as guardians of the public purse. That is what NHS England is saying, that's what the government is saying, that's what the Department of Health is saying. Now, my advice is don't let Section 75, payment by results, or anything else either get you down or get in your way. Forget the rules if necessary. The NHS must now go beyond those terrible games of the past, the vested professional and organisational interest, to start working effectively in trusting relationships based upon commitment, goodwill and trust, just as happens at that front line of general practice. And finally, I want to say a word about the clinical commissioning leaders. I see several of you here today as familiar faces. You look a little tired, but I'm glad to see most of you are still smiling. But let's put the record straight once and for all. All this talk of conflict of interest, as if GP commissioners are in it for money or some self-aggrandisement. I do not know of one single commissioning leader who is doing it for him or herself. They regard their work as a public duty, a social responsibility, a privilege. They burn the midnight oil, and they are brilliant, fearless, and full of integrity, a real force to be reckoned with. Never, never before, in my opinion, has the NHS been led by such a powerful force of motivated, committed, and yes, heroic leaders. And how often have I banged my fists at podiums like this against an NHS that is led from the centre, run by a managerial hierarchy, and where secondary care is regarded as the senior service of the NHS. Nevermore, it's all gone. The time for clinical commissioning has come. That's clinically led, locally sensitive, and with a primary care focus. And today, as we approach the second day of this commissioning show, let it be a celebration of all of that, the coming of age of clinical commissioning. Thank you. And without much more ado, we're going to now open our debate, a debate on one of those most crucial themes of the moment, the emergency care crisis. So, does the emergency care crisis exist? And if it does, why? And if it needs sorting out, why is NHS England and Bruce Keogh sorting it out when the statutory organisations holding the budgets for emergency services and ambulance care are the CCGs themselves? Or is it something that was highlighted by 111 and by some of the problems that occurred there? And whose fault is it? Let's look first at that question. What is the problem? Is it the GPs? Is it, as some have interpreted the Secretary of State saying, that it was due to the GP contract? Or is it the fact that in general practice we're unable to provide perhaps as much continuity and accountability as we did in the old days? Or is it nothing to do with general practice? Is it to do with the A&E departments, the trusts with their fairly large fairly large reserves, simply not putting the money and the resources into A&E, not front-loading the system with the most senior people to look after patients? Or is it the lack of social care, the fact that there's nowhere to put patients when they come out of hospital? Or is it in fact not a problem at all? Are we simply seeing the erosion, as we are in general practice, of a system where there's limited funding, but an increasing number of over 70 and 80-year-olds who provide 50% of the hospital admissions? Well, these are the answers and questions that we're going to be putting to our two experts today. But before we do so, I'm going to ask you a question, and I'm going to dash over here because I just remembered I've got to press the buzzer to do so. So, this is a question for all of you. Now, fingers on buzzers. Do CCGs have the capability to solve the urgent and emergency care crisis? Yes, no, or not sure. You've got 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Has everyone answered? And the answer was yes. What a wonderful, positive audience. So, if CCGs have the capability to solve the emergent and emergency care crisis, it does actually beg again the question, why is NHS England trying to solve it? Anyway, let's not go on that one anymore, but let's go on to our second question, which is, what do you think will be the most effective way of reducing A&E attendances? Is it going to be general practice getting its act together? Will it be hospital A&E departments getting their act together, better social care, better organisation of out of hours, or more expert clinical commissioning? So, fingers on buzzers, 10 seconds again, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And the answer is, better organisation of out of hours. Well, I think that's quite a surprising result, really, because most of the debate has said it's either going to be general practice or organising the hospitals. And as we've got two people debating the 19% and the 10%, perhaps we should have had others debating the other 80%. But maybe they'll defend their patch and be able to show us that, in fact, it is in general practice or in hospitals that the answers lie. So thanks for voting on that. I'm going to ask you that question again, and then we're going to compare the answers with what you've just said now. But it's now my great pleasure to introduce our two speakers who are going to do the head-to-head debate. They're going to do 5 minutes each, and then we're going to allow them 2 or 3 minutes to come back on each other, and then I want you all to scramble in and have your piece. So the speakers today are two great colleagues. On my left, James Kingsland, a GP who is National Clinical Lead for the NHS Clinical Commissioning Community. And on my right is Professor Tim Evans, who is Lead Fellow for the Royal College of Physicians Future Hospital Commission. So we've got a specialist and a generalist. And who should we let go first? The generalist, of course. James, take the podium.
Michael, many thanks. Good morning, everybody. Don't know how to follow that almost Churchillian opening, Michael. I didn't know where to put my tin hat on at the end there. And for those down at heel with your hand saying you're not too happy about the future, I was going to sing "Pack Up Your Troubles in Your Old Kit Bag." But anyway, what I want to do is just to put into context some, for the 5 minutes I've got, some of the issues that I see challenging the broken urgent care system. I think we accept that the urgent care system in UK, particularly in England, is largely broken at the moment and it needs urgently fixing. I didn't think I was going to start by quoting the now retiring Chief Executive, Sir David Nicholson, but when at another society conference last week, he did come out and say he really did like primary care and he was a great fan of general practice, and then he plagiarised one of the terms I've been using for over 20 years, that the primary care system, particularly general practice, is the cornerstone of the NHS. I want to build on that to say that CCGs, through their, if they do nothing else in the first year, but improve the capability and capacity of their members, their primary care providers, they will achieve more than probably just trying to buy services differently. So just to put into context, it is well recognised, I think, internationally, as many of international health systems look at the efficiency in our NHS and why we have a service that is free at the point of access, not based on anybody's ability to pay, is because of list-based practice. The fact we register for NHS services with that unit currently called primary care, and primary care then in England has about 300 million contacts, and most of those contacts are finished episodes within primary care. Destabilise that system, and then we will have to look at different ways of funding our NHS, something that is abhorrent to us all, we don't want to even think about. So the systems that need fixing, long-term condition management, health inequalities, and particularly the urgent care system, is about investing in list-based practice. And we see if we destabilise that, and some would say the 2004 contract was a significant change in how the management of demand in our NHS was compromised by taking general practice out of 24/7 care. Well, clearly that's just an assumption. There are many reasons. We assume that it's the Francis report, it's the reform programme at the moment, the lack of investment in social care, the loss of beds in hospital, the lack of staffing or the lower staffing in hospitals. Yes, the 2004 contract, but particularly the management of demand in the system. And as we've seen over the last 10 years, how the management of demand on our NHS has changed and general practice has been taken a little bit away from that. And yes, the 2004 contract is a factor. We have produced new systems to meet that demand which don't really understand the nature of the demand, because demand management is about understanding the demand and then shaping the demand. And there are some good evidence, which I'll just, if I may, highlight about how we can use it to shape or improve urgent care systems. But meeting demand by just improving capacity, building walk-in centres, yes, I was the medical advisor for walk-in centre development. They didn't quite turn out how they were meant. They were supposed to be complementary services for general practice, not urgent care centres. Anyway, that's another story. NHS 111, NHS Direct, minor injuries unit, or even the thought of creating new urgent care services in the community is not the solution. Part of the solution is the investment in primary care, particularly general practice, the primary care home, to allow the expansion and finishing of more episodes, making more and buying less for for patients. And we've got some evidence already. I just want to quickly cite 3 programs which are making significant differences. One is the patient access program that some of you may be involved in. A number of practices around England are using a system of triage in its true sense, because we use triage in a completely upside down manner in our NHS. Triage was brought in when it was in the First World War, going back to my tin hat now, where the most experienced would triage to the least experienced. We do it the other way around in the NHS. But where triage is working, general practitioners, being the first port of call for the access, have shown in practices across England consistently a reduction in face-to-face contact and an increasing the capacity to take on more urgent care, more same-day work, and finish today's work today by about a third. The second is a rapid response system to home visits. And there's good evidence that the longer you leave between the request and the delivery, the more likely a blue light is called. And a number of practices all over the Northwest have shown a rapid access or a rapid response system to home visiting can reduce the need to be transferred to A&E significantly. And thirdly, and I'm sorry I'm going through this rapidly, is the never full practice. My practice is one of a number that is saying that we are never full. So that between our opening hours, and we do open till 7:30 at night, but generally for the contract hours of 8 till 6:30 p.m, no patient is ever turned away. We've done it with a bit of resourcing, and I can build on that if we have time in the debate. But when we're starting to analyse when patients access urgent care, and we're finding this consistently across our patch, and it is being reproduced by the evidence in other areas of England, up to 80% of all urgent care, and what I mean by urgent care is attendance in A&E, use of walk-in centres, minor injuries unit, contact with NHS 111. Up to 80% is between the hours of 8 a.m. and 6:30 at night. It is during the daylight hours of general practice. If we have a never full practice, what we're also finding is that the need for GP out of hours services, we've found that by having a never full practice, the number of calls made between 7 a.m. and 8 a.m. to GP out of hours, and between 6:30 and 9 p.m, for a practice population of 5,000, it's 1 call every 4 weeks. I would suggest that it would be something that GPs or general or primary care would take on, an extended role, maybe the phone call system from at least 7 in the morning till 9 at night, because it is a time, if you have a never full practice, where you don't need a GP out of hours service. The resources that are released by having GP out of hours, which again our evidence shows that you need less personnel during the out of hours time, which could be 9 p.m. till 7 a.m. The use of walk-in centres. We are seeing that some areas are closing walk-in centres, and there are concerns from politicians, but where they have been closed, I'll quote Nottingham that have closed, I think, 3, they found that the demand on general practice as a result of closure of walk-in centres has gone down.
30
and the national evidence...
30 seconds.
I'll finish that, Chairman. The national evidence of walk-in centre utilisation is that 50% of all patients going to a walk-in centre are seen by their general practice with the same condition within 1 week. So I suggest the management of the demand on the system is an investment in list-based practice, the general practice which is going to be challenged to step up to the plate, and CCGs challenging their members to make more and buy less for the populations they serve. Chairman, thank you.
Thank you. So James, thanks for the case for general practice. We now go over to our specialist, Tim Evans. Tim.
Thank you very much, Michael. It's a great pleasure to be asked to speak here, albeit with some trepidation, to enter this hall of GP commissioning heroes as a hospital specialist. I've only got 3 points to make, and I'll be fairly brief with those. The first is to say, is there actually a crisis at all in healthcare provision in the acute sector, in the hospital sector? And the answer is undoubtedly yes. You will have heard in recent days and weeks the concerns expressed nationally and politically about this, but we now have 20 million A&E attendances per year, when only 2 years ago we were running at 16 or 17 million. And that's in the context of a shrinking hospital bed quota The number of hospital beds has shrunk, as you will know, over the past 25 to 30 years by about a third, and some of those, not a substantial number, but a significant number, are within the acute sector. So we have fewer hospitals and fewer acute beds with an increased workload at the front door, and this of course knocks on and impacts adversely upon the elective work that hospitals also need to do. And this was all highlighted in the RCP's report, Hospitals on the Edge, which was launched last July and provoked the Future Hospital Commission, for which I am the lead fellow, as you see. Second question, why? Why are 20 million people attending A&E departments every year? And I think there are three reasons. Firstly, some should do. If you have an acute myocardial infarction or a stroke, you should go straight to hospital. Indeed, you should probably bypass the A&E department and receive the care that you need. And that is, of course, a function of the past decade. Prior to that, you had a stroke or an infarct, it was managed wherever you happened to find yourself. So some patients should do. Some patients must do. The 400,000 frail elderly patients who live in care homes often have no choice, despite advanced directives and I'm sure excellent primary care afforded during working hours. The default position is to admit those patients to hospital. They must go to hospital because the care that's provided to them in those care homes, not all of them I'm certain, but at least some, is not adequate for their needs. And lastly, some want to. A lot of patients want to come to A&E. They must want to come because they know they're going to have to wait 4 hours when they get there, and 1/3 of them, 1/3, are going to go away with advice. So why do they want to? Well, firstly, they want to go where the lights are on. And the lights are always on in A&E departments. Secondly, they have the confidence, presumably, that the staff they see, and many of them, of course, are specialist staff dealing with the area of concern the patient may have, and, of course, with access to all the things that Michael has rightly emphasised, x-rays, blood tests and the like. That gives them confidence. So the third question, what's the way forward? Well, the first is not to put the clock back. You cannot. The idea that we can go back to some halcyon day when I was a general practitioner in the 1980s, hauling an ECG machine around the countryside in the middle of the night because I thought that was an advance I should afford to my patients, is completely inappropriate. We need to define what general practice does. I'm not being facetious. I have no idea what my general practice does. Does it afford me 24/7 emergency care? Will it manage my stroke, my infarct, my diabetes? I don't know. I have absolutely no idea. I do know it affords first-rate antenatal care, it vaccinates my children, it provides health-care screening. These are invaluable things, and I know it does that. What I don't know is where general practice stops and secondary care, escalation of care starts. And to my mind, we need an integration of the two. We need to bring together general practice and hospital care. We need far more hospital specialists working to support general practitioners with specialist clinics. And we need far more access points to the service that are coordinated and facilitated by excellent IT. The Future Hospital Commission of the Royal College of Physicians, which is to report in September, is going to put some ideas in place that develop that model, and as far as I'm concerned, it is the way forward. It's not hospitals, it's not general practice, it's both, and it's deciding precisely what each contribute to the healthcare of the nation and where and when patients should access each portal. Thank you for your attention.
Thanks, Stu. Well, thank you both for a very refreshing start to the debate. I mean, it's good to know, first of all, that general practice and hospital are up for this rather than handing it to each other. I'm going to ask James to respond, and then Phil to respond to James, and then for you to respond to what you've heard them say. James.
Thanks, sir. I would not disagree, and there's no question that one of the factors, and it's just one of the factors in our urgent care problem, is the fewer beds and staff in hospitals. There's no question there's the pressure on that system is something we have to look at as part of the solution, and the solution has got to be a collaborative process. But some of the international evidence around how healthcare systems can efficiently manage demand and resources, quoting Barbara Starfield, who sadly, it's almost 2 years to the day that she passed away. A great loss, who was a great advocate of primary care. Her research between the 1970s and the late 1990s consistently showed that a strong system of primary care and the practice characteristics within that primary care system, particularly registration and longitudinal care, was associated with improved health and resource utilisation, and also in analysis of reforms in lots of healthcare systems over many years, there's a consistent lack of investment of primary care that often compromised the ability of those reforms to make the changes that were planned. And finally, that primary care orientated health services improves efficiency in resource utilisation. So there's good evidence, and as recently as January this year, the Commonwealth Fund report that compares healthcare systems across the 11 OECD countries again showed that the primary care system, particularly in the UK, consistently met the parameters of efficiency and how to manage demand as the top ranking area. So my argument is always to look at the crisis, and particularly if we're looking at A&E, where some evidence is that up to 80% of attendances are not accidents or emergencies. And our own evidence locally is that 90% of the urgent care that's going to other systems, whether it be the walk-in centre or A&E, could be safely and appropriately managed within a primary care environment. They're just turning up at the wrong venue, and the primary care environment is struggling because it is full, and we need resources to improve the capacity, yes, and the capabilities, but I would strongly suggest that the investment in that system through both the international evidence and what is gathering momentum in how general practice is seeing that with new resource they could become the never full, the properly triaged and extended care system that our patients deserve.
So quite a challenge then for you, Tim. James saying that primary care could actually take over an awful lot of the work that you're doing currently in A&E departments. I think he's implying it could be done cheaper and better, doing you out of a job. Is that a good thing, Tim?
Absolutely. I'm delighted, and as soon as it happens I shall retire, and I'm sure many of my colleagues will. I think, as James has said, general practice could be extremely efficient, and I'm sure in many areas of the country it is, but unfortunately we are still left with 20 million people voting with their feet, 80% of them in James's terms, who wish to come to A&E. And I think the idea that we can turn back this tide, if you will, we can alter the desires of patients to go to A&E by saying, look, there are bigger and better general practices, has not proved to be the case. And I think I go back to my central argument, it is, tell me what general practice does. That does not mean it does not provide an essential, excellent, first-rate service, but patients need to know where it is they're supposed to go, when they're supposed to go, for whatever condition it happens to be. Now that may be something that commissioners can indeed take on. In my view, and I've worked in the United States for quite a while, having a single point of access to the healthcare system rather than 3 or 4 sets of different telephone numbers, primary care when it's open, accident emergency when it's not open, an urgent walk-in centre, a private centre at the station. Most of my patients, I'm certain, don't know which part of the service they're supposed to access for which service they're trying to get access to. So to my mind, the first most important thing is for general practice in a unified, uniform and across-the-board way is to say what it is you do and when you do it. And then we can start with that and find out where hospitals need to fill in the holes.
Right. Well, thanks, James and Tim. Both very lucid explanations, both very clear. But we're going to ask you what you think. And I have to reflect, first of all, what you've already said. This audience doesn't seem to think the answers are either in general practice or in hospital. They think the answers lie in much better out-of-hours services. What's your answer to that? 30 seconds each.
I'll just reiterate what I was saying earlier, that if you analyse the demand on urgent care systems, the biggest proportion is during the daylight hours. Okay, it includes Saturdays and Sundays, and we have to think about that, but it is during the hours of 8 a.m. till 6:30 p.m, not GP out of hours time.
And I'd say, as one who still works out of hours and at weekends, that's not my personal experience. But I think the answer is indeed for better out-of-hours care. I'm absolutely convinced of that, and for general practice and hospitals to combine to provide that service.
Right, so an integrated service
Absolutely.
between general practice and hospital care, then we wouldn't need out-of-hours providers. Right. So, now who is going to enter this debate? Polarised perhaps at this end, over here. So, we'll start there, and in fact, let's have lots of views, so lots of hands up if we can. One over there. Over here. If you could say who you are and very brief.
Hello. Thank you very much, Michael. Nice to see you again from the fund holding days. I'm Dr. Bose. I'm from Thurs NHS CCG. And I can agree with both the speakers that what we've done in Thurs and basically in that area is that we've got a GP in A&E who looks after the primary care problems, so everybody doesn't enter into the A&E system. They are separately. As far as the
Integrated it yourself
Yes,
already,
yes.
because you've got general practice actually in the A&E sector.
Absolutely. And then the signposting is there. The patients who don't need to see the A&E, they are automatically signposted to the GP in A&E. The second thing what we're doing is this patient empowerment and signposting. Unless we do that what services are available and how they can access, I don't think any other formula will work.
Thank you. Thank you. A view over here.
Hi, James Stewart from Surrey Health Watch. Surely A&E and the pressure on the system is a symptom of a broken system. We really need to understand what the patient's entire journey is, and I guess understand their demands and meet their demands through providing the right capacity at the right time. I guess also the integration of care and health also needs to be considered, and that we need to ensure that patients see a seamless journey through their care provision, and actually the question should be around integrating that. And I think really coming back to your point that primary and secondary care is of no consequence to the patient. Actually what they want is a seamless journey.
Thanks. Integration. Over here.
Hello, nice to see you again here. Those good old fund holding days. I'm Dr. Ashok Deshpande from Havering CCG. Just to take one point, is the most important thing is the patient education in this country. Why patients end up into A&E for minor illnesses? And that education needs to be coming from politicians, number one. Number two, from the medical politicians, they need to let the patients know that they don't need to go to A&E for minor illnesses or minor elements of their health.
Well, thanks very much. I'm going to ask Tim to answer to that, because I think Tim's point is you don't know what general practice does, so what are we going to educate people on if we don't know where they're going to go?
I think it's an excellent point, and patients do need to be told when and where to access the integrated healthcare system according to their needs. Absolutely.
Great. Over here.
Hi, my name's Steve Clay. I'm a GP in Leicestershire and I work with a company called Productive Primary Care. We use a system called Dr. First, which is, in our practice has meant that, for example, our over 75s have got the lowest A&E attendance rate of any practice in the whole of the East Midlands. And practices that work in a similar way to us have shown at least a 20% reduction in A&E attendance, because they achieve the three things that you've just said, James, which is rapid access to telephone consultation and thereby rapid access to face-to-face consultations with the GP where appropriate, appropriately urgent visits at home, and a practice that's never closed, because the capacity has increased in our practice by at least 50% by using that system.
And will we be able to persuade all GPs to want to do the sort of things that you and James are doing?
No.
So is your answer just for your few thousand patients?
No. When I say no, there's always a little tail, isn't there, that you'll never persuade. But we might manage 95%.
And that would be how? By money, persuasion, shame?
Well, the beauty of it is, as well as saving the NHS budget over £1 billion a year by A&E attendance, you're also going to save the practices about the same amount in their own pocket by the reduction in manpower that they need. So who's not to love it?
Great. Now, over here, let's have some thoughts from the back.
Hi,
It's not a free ride, you know.
I'm Sheila Niegi. I'm a GP in Pimlico from Central London Health+Care CCG. Working in Central London, I have access to several hospitals, several specialists, several A&E departments, as indeed all my patients. The emergency problem is huge, and we've all been asked to get involved and sort it out. I think, going back to the GP perspective, it would certainly be easy for GPs to manage a lot more problems during daylight hours if they could access the advice and support of our secondary care colleagues. We need to go back to how many years ago you could ring up a colleague in hospital and ask for a bit of advice. We are generalists, we are not specialists, and sometimes we do need just a little pointer to help us keep a patient at home. What has happened with the changes recently, it is virtually impossible to talk to anybody who is a specialist in hospital. And I'm talking about having, 5 or 6 teaching hospitals at my behest. Can't talk to anybody. So I agree we need to have an integrated system. I had a very good case of a patient who was desperate to die at home, was discharged the day after coming out from ITU. I had a fantastic colleague in hospital who helped me manage that patient's renal failure at home as a GP with district nursing supports for 2 weeks. So the integration needs to happen, but there has to be buy-in from hospital consultants to go out of their comfort zone of clinics and outpatients to help GPs provide that service in the community.
Thank you. Well spoken. And I suppose that is the job for the new clinical commissioners, to make sure that they bring the two sides together. Any clinical commissioning leader care to comment on what we've just heard and perhaps stuff that they're doing to try and make this happen? Over here.
Yeah, again, we have organised a group of the specialists in the primary care and the secondary care, and we have formed a body where the primary care is talking to the secondary care, developing new services or service redesigns. We are also talking to the community care providers, and they have provided their rapid response. And with our secondary care colleagues, we have established geriatric care in the community. And all these has reduced the workload on the GPs while the care provision has improved.
Thank you. Point from over here.
Thank you. My name's Kate Davenport. I'm a practice manager just south of Bristol. One of the things that we've been discussing at great length in our area is the social care crisis. The problem that we're perceiving is that A&E is getting log-jammed with patients who need to be moved onto the ward, can't be moved onto the ward because of patients who are ready clinically to be discharged, but there is nowhere for them to go. I noticed that when we voted to start with, quite a large proportion of the audience felt that the problem is with social care, but neither of the speakers has mentioned that, and I'd like to know your views, please.
Good. Well, if you can store up your views, because I'm asking you 2 speakers to make some final comments in 3 or 4 minutes' time. We've got another view back here.
Yes, hello. I'm Tony Moore-Kane from Derbyshire. I'm a public health doctor, and I also do clinical sessions in the local A&E department. You seem to be creating an argument for general practice to do more provision. Wouldn't it have been a much more logical structural arrangement if CCGs transformed themselves into clinical provider groups? And I'd argue with such a structural rearrangement, merging with the local secondary care services would be easy peasy.
Well, yes, we'll ask them to answer that in their final summing up. I'm going to pick on two members of the audience shortly who don't know who they are, but before we do that, we're going to go for our last question from the floor, over here.
Hello, my name is Carl Edmonds. I work for the CSU in North and East London. One group of patients we haven't mentioned yet are those that go to A&E because they simply prefer or perceive better care in hospital. And we've already mentioned about improving patient education, and I'm assuming that means around self-care. But what are we doing to work with patients to make them realise that perhaps the best care they can get for their conditions might be with their GP or within primary care? And how can we improve the relationships these people have with primary care to make them feel more attracted to using their GP as their first port of call?
Well, thanks. That's a really good point. And again, I'm going to ask you to address this in your summing up. But this is the commissioning show. And I've seen two people who I think ought to give us their answers, but one, a charismatic clinical commissioning leader from Oxford, and the other, the leader of a commissioning support unit. Now, I want you two to reply in 30 seconds to what you've heard as to how commissioning is going to sort this out.
Okay, teamwork. It absolutely has to be. So whether that's between the CCG and the CSU, whether that's between general practice and secondary care, whether it's between the NHS and social care, this is too complex an issue for us to try and have single organisation solutions. The other is the use of evidence. Stephen and I were talking earlier on about actually analysing what is really going on and using that evidence to try and tackle the problem rather than doing it on the basis of anecdote.
Right.
Thank you, Michael, so much. Very kind. I think I reflect that it's not the GP contract change in 2004 that changed the world. It's the commissioner-provider split, payment by results, that has created a chasm between our hospital consultant colleagues and primary care. And commissioners now, please note, clinical commissioning, not just GP commissioning. And yes, that it does include nurse colleagues here. It is about us rebuilding understanding and trust between the various parts of health and social care. Coming to one of the other points, Michael, if I may, which is why have we got 4 million people more attending A&E, is have we actually properly, in an evidence-based way, asked enough of those who are attending what the problem is? Why are you here? Because I don't think that unless James or others can answer that I can see anything resembling an evidence-based answer to that question.
And you, Stephen, as the chair of one of the largest clinical commissioning groups in the country, are you asking your patients that?
We absolutely are undertaking academic study with our Oxford University colleagues to try and find some local answers, probably some months before there are any national guidance that will really address this question. So actively working on it, even those back at Oxford today.
Well, thank you, Stephen. Now, I'm going to ask, finally, our two speakers to do a maximum, absolute maximum of a minute to try and attract your votes. They're a bit like the Lib Dems and UKIP in the sense that, as we saw, the biggest vote did go for out of hours earlier, but we'll see which wins in the final vote, general practice or hospital emergency care. So, are you ready, guys, to answer the questions you've been asked and to win your votes? James.
Michael, thank you. I'm going to do the politician's answer and not answer any of the questions that were set, but just what I think. There's no question this is our last chance to rejuvenate the NHS. We've got a broken urgent care system, we've got a reformed long-term condition management, and we've got health inequalities gaps that are as large as they ever were. Just having said that, answering some of the points, if we'd have called this the reform of primary care provision reform, not clinical commissioning, I think more of us in primary care would have got it. And if CCGs, I'll reiterate, do nothing more in their first year that look at the capability and capacity of their member organisations to invest in them to meet some of those demands, we'll do more than just trying to buy differently or ask others to act differently on our behalves. One of the things I just want to throw in at the end is we do have to reform contracts. So, for example, if we are going to repatriate a lot of work out of A&E. We've got to have a different contract with A&E. We've got to have contracts that don't require A&E to have a duty of care for everyone who turns up. We've got to have immediate access back through a direct appointment system back into general practice. What is clear, though, there is no single factor for the rising tide of the broken or the need on the urgent care and the A&E service, and it's a multifactorial problem. And I would agree that the solutions is going to be in the collaborative approach across all sectors and an integrated system that meets this major challenge.
Thanks. A very passionate reply, James. And Tim, you've got the final word.
Thank you, Mike. I mean, my view is actually the NHS isn't broken. There have been enormous advances in the care that we offer to our patients over the last decade, and massive advances in the treatment of many very serious conditions. But I do think we are now in a position where everyone in this room, everyone in hospitals, everyone in general practice, everyone providing social care, has to get together and decide which part of the care pathway you're contributing to, and make absolutely certain that that integration of care is spread out in a uniform and recognisable way across the country, across England at any rate, and to ensure that our patients know precisely what it is they can expect from each part of that care pathway. Integration is the key, and we all are responsible for out-of-hours work, hospitals, general practice, social care, everybody.
Well, thanks, Tim and James, for a passionate and well-argued debate. As always, the final word is integration. That means peace, I think, and unity almost between the two of you. But I'm afraid we do have to, just before we close, review our voting system. And we want to see who's won this debate. So I ask you again the 5 questions. What will be the most effective way of reducing A&E attendance? Do you believe, as James does, that it's going to be solution-centred on list-based general practice? Do you think, as Tim does, that hospitals are the place that we need to be putting this care at the moment until general practice gets its house in order? Is it social care, as some of you have said? Is it better organisation of out-of-hours, as most of you said to begin with? Or is it just better commissioning by people like Stephen? So, the floor is yours now to vote, and forever hold your peace, as with every election. I'll give you 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And the grand result of this debate is... Wow! Goodness me! So, just to let you know, you really are a very volatile electorate here. Maybe this is the sign of times to come in the next year or two. But if you remember, most of you said D, better organisation of out-of-hours, and it looks as though Tim and James have totally argued it out of that. You know, you've all deserted your posts there. Expert commissioning, it seems as though you've got confidence in people like Stephen to do it. But James, I think you win the day with this extraordinary change in the voting patterns to say that centre list-based general practice holds the answers. Now, that is quite an interesting result, because we already heard from a GP colleague at the back that, yes, he felt he had the answers, but maybe not all general practice did. So let's watch this space. Let's see if general practice can step up to the plate, because as Tim said right at the beginning, if it can, he's not bothered. Thank you for coming, and look forward to seeing you at the plenary later on this afternoon.